So welcome back to Endoscopy Essentials in our magnificent EMR series with Michael Bourke. Michael, welcome again.
Thank you. It's great to be here.
We are sitting at DDW and continuing our series. The last one we ended with the technique of hot EMR. Now I think we're going to cold.
Yes.
At least technically.
Yep. Yes, I agree.
So please, show us.
Well, polypectomy's changed a lot in the last 5 years, but for the longest time we always did hot snare resection. This is an example of it here, maybe a 15 to 20 millimeter polyp. Conventionally, we'd make a submucosal injection and then snare the lesion off, often in one piece for this size, and then treat the margin with snare tip soft coagulation like that. Very carefully examine the defect to make sure there's no muscle injury or deep mural injury, and then we can be confident the patient could be discharged same day. But the problem with hot snare polypectomy is complications, so bleeding and perforation. The perforation risk, at least after EMRs, around 2%, and then post-procedural bleeding, depending on the location in the colon, overall about 5 to 7%, but in the right colon 10 to 12%, and 2 to 3% in the rest of the colon, maybe the rectum, it's 5 to 7% after EMR. So if we do cold snare resection, we can eliminate these two problems of perforation and bleeding. So
maybe not entirely. You know, there are recent data from DDW here where there were some complications also in the cold group.
Yeah.
Significantly less, but it's not zero.
Yeah, so so not entirely. I agree. There's a small risk of bleeding and there are case reports of perforation, but you know, it's
by and large,
it's quantum leap safer for sure. And it's technically just as effective. The problem is, recurrence, but we'll come to that. So this is a video demonstrating the technique of piecemeal cold snare polypectomy. So for lesions larger than 15 to 20 millimeter or around that size, we generally make a submucosal injection. Don't start in the center. I'll start the video again.
Before you do cold snare injection, what's the concept? Injection or no injection, and which type of snare?
Yeah, so I think, for lesions less than 10 millimeter, if you look at the evolution in the guidelines, in 2017 we said 5 millimeter and less, all cold, and now the guidelines say 10 millimeter and less, all cold. And those lesions don't need to be injected. But as the lesion gets larger, making an injection creates tension in the submucosa, so the excision is more precise and easier, and you can follow the margins so much more clearly. If you use a little bit of adrenaline, it minimizes the bleeding. We know that intraprocedural bleeding is an independent risk factor for recurrence. So making an injection for a significant lesion makes things easier.
So above 1 centimeter, rather inject?
Yeah, depending on your own scope of practice and expertise. But generally above 1 centimeter, I think most people should be injecting. If you're an expert, then of course you can probably...
And with blue as usual? With
blue, yeah. Indigo carmine's preferable. It's biologically inert. Methylene blue can cause a bit of a mucositis, and the colouring's not as favourable, so we prefer indigo carmine. And you could just use saline. But after you make the injection, because we're all using scopes with foot pumps, you only need to make the one injection, and after every excision you can use the water jet, or we use saline in the water jet actually, so it's a saline jet. You can use the saline jet to expand the submucosa and keep a nice cushion and keep the tension within the submucosa so you can keep excising. In terms of the snare, it's best to use a dedicated cold snare, stiff, thin wire, 0.28 to 0.3 millimeter in diameter. But we did show in a big randomized trial that actually you can use either a stiff, thin wire dedicated or a conventional snare, and incomplete resection, as proven by 4-quadrant biopsy, was around 1% in either group, randomized 650 patients. So in fact, the key thing is technique.
Because that's a frequent question. Can we use our usual snare if it's thin, if it's a monofilament snare? Can I use it for cold as well?
You definitely can.
Okay.
It's not as elegant, and you may get cold snare protrusions. And there's recent data to show, although in the original Tutucci study that we published in 2013, when we first described the cold snare protrusion, we took biopsies of 300 protrusions or something. There was no residual adenoma in the protrusions, but recent data does show that with protrusions you can have residual adenoma. So you want to not be so greedy, don't take too much so that you don't end up with stalling and you have to amputate the snare against the edge of the scope.
There are special snares with reinforcement of the sheath, at least distally. Are they preferable for difficult situations, or?
I think definitely it's better to use a dedicated cold snare. They're inexpensive, and in fact, on any screening list. So if you're doing screening colonoscopy, I just do screening colonoscopy on Mondays. We could go a whole year without attaching a diathermy plate. So cold snare is really, it's 98% of the work.
Okay. So let's get back to the video.
Yeah, so here's the lesion. So it's a sort of 2A lesion, a little bit bulky, maybe a nodule in the middle. We make an injection.
Also extending a little bit, which you see now.
So this is just to demonstrate, don't start in the middle. Start at one edge, and we usually say half normal tissue, half mucosa. So you can see here, this is half the normal, this is the half of the lesion here, and this is half normal mucosa. Then you create a beautiful plane. So we like to use a 3-stage snare closure. So place the snare over the target, push down very firmly with your up down. You can see the tension in the submucosa here, how we've pushed down very firmly. So we're not going to graze the surface. We're going to do a mucosal excavation. We're going to really take this tissue, a piece of 6 to 8 millimeter, and we're going to, so 3 stages, close to resistance. First of all, I'll cut that bit. So 3 stages, close a little to make sure that the snare seats in. So here we've closed a little, and you can see that the snare is seated in. And at that moment, you pause a little, right, it's seated in. Now close to resistance, and then cut. And I like to use those 3 stages. As you get, when you're very confident with it, you can work with your assistant, and it doesn't take 3 seconds to do each resection. You just say, close a little, close to resistance, cut. Yeah, and the assistants will just be right in tune with you, and you can work quickly through the polyp. When you first start doing cold snare resection for polyps that are, say, even larger, 20, 30, 40 millimeters, it used to take more time than it took to do EMR. But now, with expertise and experience, it takes much less time. So here, we'll play the rest of the video. So, sorry, we go back to the beginning. So here's an injection. Of course, we first examine to make sure there's no concerning features. And don't place the snare in the middle. Onto the edge, aspirate gas, reduce the footprint of the polyp, push down firmly, and then cut, water jet into the defect. And then you work, this is also very important, you work from the edge of the expanding submucosal defect. So don't randomly pick away at the polyp, work consistently across the polyp from one direction to the other. Here we've created a protrusion. It's probably okay, but we can go back and re-excise it if we're concerned. And this is like a 6-bite excision for maybe a 20 millimeter polyp. Is there residual adenoma? Don't die wondering, just chop it off. This is the beauty of cold snare resection. You can continuously expand the defect, and I like the defect to be about 1.5 times the size of the polyp. So I'll always, go for more. And I see sometimes the nurses tell me that some people, they'll have a polyp like this and the snare will go round, and then they'll downsize the snare. You don't downsize the snare, just take a lot of tissue around the lesion.
So it's the fear from the hot resection, right?
Yes,
So
that's right. It's a historical overhang, an unusual one.
So a few questions to that. First is the protrusion. So how often do you do sort of secondary resection, deeper resections?
Yeah, so
after re-injecting with the flushing?
Yeah, so we'll use the water jet to expand it out. Look carefully, but often then you can't tell because the image is corrupted, the planes are all different. And I think if you have any doubt, just re-excise. That's the beauty of cold. You can,
even into the depth.
Even into
not
the
only
depth.
The margin.
Yeah, the only time you'll get so all the case reports. So as you go deeper, of course, you're worried you might injure the muscle layer, but all the case reports in the literature are related to polyps that have been previously attempted. So, for example, in a patient with SPS, serrated polyposis syndrome, oftentimes you see there'll be a scar with a little bit of residual. You have to be a little bit careful there that you don't, are not too aggressive, because there might be, the muscle might be stuck to the scarred residual. So, but otherwise I think you can be, safe.
There are also people saying it's almost impossible to resect the muscularis cold. But
we've look, I know of several experts who've had at least one perforation. We have two, but recognised during the procedure. That's the whole thing with perforation, but that's a separate topic. So it can happen, but I encourage you not to be afraid and to make a big defect and to be totally certain that you've excised all residual adenoma. So if you look at the defect, you think, gee, I don't know about that area, just cut it off. It's as simple as that.
Okay. Other question is, there was very little bleeding here, but sometimes there is acute bleeding. And the message is, don't worry, flush and it will go away automatically. It's really amazing.
Yeah,
coming
because
from the hot field and
Yeah, so intraprocedural bleeding during cold snare polypectomy doesn't predict delayed bleeding unless it's pulsatile. I think in my whole career I've only had one, and I must have done tens of thousands cold polyps. And just use the water jet, go away and do something else, go to the cecum and come back. It's all stopped. It doesn't matter how much blood you see. There's nothing to worry about. The only concern I would say is if you've done cold snare in the rectum, you need to tell the patient that they may see some blood in the stool for the next few days, but they shouldn't be worried. And I always say to them, if you're bleeding, you'll be passing bloody stools every half hour to hour. But if you see blood with a normal stool or a little bit of blood a couple of times a day, it's nothing to worry about. So this is a video of a 20 millimeter lesion in the cecum managed by cold snare. It's an adenoma. So we inject, it's near the appendiceal orifice, little tricky spot. And now here comes the snare. As I said before, tension, firm downward pressure, stage snare closure. Everything's sped up. It's not sped up, but it's edited just so we can get through the video within 40 seconds or so. Everything's proceeding well. Saline jet to expand. Now they're stalling. So often then, if it won't cut through, don't attach diathermy, but we can amputate against the end of the scope. But this creates a protrusion. So therefore we re-excise that area and amputate again. It's obviously a little scarred. There's a big protrusion. Flatten it out by the saline jet. And then you might even consider to re-excise that. And here now, is it done? It's a bit untidy because it's close to the appendix. Here we see possibly a small island of residual adenoma. So as I said before, don't hesitate, just re-excise, and this is the end result. So
again, a few questions. You said amputate. You don't have any worry, because I experienced one small perforation in the duodenum. Perhaps I had too much, but pulling it against the...
Yeah, so the duodenum is totally different.
Okay, so colon, no worry.
Colon, no worries, because the colon is mobile and the muscle just, tends not to come up. But the duodenum is retroperitoneal and fixed, and the muscle layer can be easily torn. So you can tear it if you're trying to use clips or... So we had a couple in our series of cold snare resection for duodenal polyps, 50 patients. great outcomes, but recurrence is greater, but no bleeding. But there were 2 perforations, luckily both recognised. Yeah, so cold snare resection, you have to be very careful in the duodenum. It's completely different technique. We won't cover that now, but don't be thinking it's the same. It's not.
So no worry in the colon. And then let's get back to the protrusion. You said initially, based on your paper, everybody said it's just a protrusion, no adenoma.
Yeah, so
but that has changed, right? So there might be little remnants, or?
Yeah, so in that original paper, we biopsied all the protrusions, and there were mucosal remnants, but no epithelium. So you could find muscularis mucosa in 10 to 15% of the protrusions, but no epithelium. But a recent paper has shown that protrusions may contain residual epithelium. So I think you have to be very careful about protrusions. And so that means that we need even better dedicated cold snares that slice through so much better. So we're not getting, because the protrusion is just bunched up submucosa and muscularis mucosa. So we want a cold snare that's strong enough, wires are thin enough that we can cut through the muscularis mucosa into the superficial submucosa, because the plane of excision with cold snare excision is 80% of the time in the actual mucosa within the lamina propria.
So what do you do if you see this?
So if we see it, first of all, to avoid it, don't take 2 big pieces. Use a dedicated cold snare, take your time, work systematically, try and avoid over capture. And then if you do get one, then saline jet, expand it, look carefully and re-excise.
Okay. So you should get rid of all of them, basically.
Yeah, when you re-excise,
risk increase of recurrence.
Yeah,
which is big enough anyway. Huh?
Yeah, and when you re-excise, in fact, you end up with you often can end up with another protrusion because so it can be a little frustrating. So you have to maybe take it in 2 pieces when you re-excise.
But never hot. Changing to hot.
No, because we already made the commitment not to expose the patient to diathermy, and I don't think there's a benefit.
Because that's also a frequent question. If I don't get along, how readily I should change over. So rather take a better snare and not switch on the current.
Yeah, but these days we're obsessed with safety, as we should be, and I think we can just continue with the cold method. I mean, if you were in an extraordinary situation where you thought, gee, maybe the histology, it could be a bit high grade or something, maybe you switched. Well, I don't like the idea of switching to hot. If you think the lesion is an advanced lesion, you should do it by conventional EMR and preferably en bloc, for example.
So in very exceptional cases.
Exactly, yeah. Okay. So as I said, on our screening list, we almost never attach a diathermy plate.
Okay, so let's go on.
So this is another example. Large flat lesion.
Not easy to see.
Not easy to see, but of course with enhanced imaging, we can nicely see the margin here. So this is a non-granular lesion.
Sometimes they escape AI, huh?
Yes, yeah, definitely. You can look straight at it, but that will change. AI will get better. So of course with this type of lesion, injection, very important. And then systematic approach, wide resection. You see this is going to be an enormous resection. And this is an older slide, but at that time we said that randomized trials are required. And of course here you see the size of the resection for, so probably 1.5 times, totally clean, beautiful, water jet, expand it all out, flatten it out. Any doubt, excise more. Okay, we're coming to serrated lesions. So the evolution of hot snare resection for larger flat polyps in the colon started with serrated lesions. And the appeal of the serrated lesion is that it has a low mucosal profile and the mucosa is thinner. It doesn't have the chunkiness of an adenoma. So the cold snare excision works beautifully. This is one of the first cold snare resections I did for a very large serrated lesion back in the teens, the 2000 teens. And this lady was on warfarin. obligate warfarin because of a mitral valve replacement. So we just did it cold. And you can see we got a small protrusion, but otherwise we could make a magnificent excision. And here we see, this is also the thing, is that they do get scars in follow-up. So scars after cold excision occur with, I think, equal frequency as a hot excision. So this is the scar in follow-up. And this is an older talk, but even at that time I was saying probably all SSP can be managed by piecemeal cold snare resection. Now we know actually every serrated lesion should be managed by piecemeal cold snare resection because it's so safe and it's very effective. And in the bigger studies, the recurrence rate is only, low single digit numbers, 2, 3, 4%. Whereas with adenomas, we know it's much higher. So there's simply no reason not to do cold snare resection for any serrated lesion of any size, unless there's dysplasia, which is a different argument. So again, this is another serrated lesion. So we didn't inject here, but start at one edge, water jet to invert the defect edges, and then excise as much as you need to be certain. So large excision, beautiful water jet or saline jet into the defect, and you can see a wide excision. No doubt there's nothing left. This is a subtle serrated lesion. Even with MBI, it's hard to see the margin. Here it is here. And then...
it's almost better seen on the left side.
It's true, yeah. So one of the tricks, of course, is to not wash away the mucus too much. So we always say with any adenoma, clean the lesion thoroughly before you begin your inspection and resection. But if you see a lesion such as this with some adherent mucus, you know it's a serrated lesion. It's the same color or lighter than the background mucosa. So maybe if it's very subtle, leave the mucus. The other thing to do sometimes is I put a little suction marker. So I just suction the lesion a little bit. It'll get a little bit friable, and then you won't lose sight of it. And when you're doing your withdrawal, if anywhere in the colon you see some adherent mucus which is defying gravity, so it's sitting opposite the fluid pool, always consider that there could be a serrated lesion under there. So you've got to wash a bit, look carefully, because often there are serrated lesions in those situations.
Or focal yellowish remnants.
Yes, yep. So this is a different example. This is what I alluded to earlier. You see here, this is a patient with serrated polyposis, and you can very clearly see this scar. And then here, when you see a scar in a patient with a previous serrated polyp, and you see some yellow remnants adherent to the scar, you know there's residual serrated tissue. It's like the yellow remnants are saying, here I am. So then we have to excise, but we need to be a little bit careful because look at this. See, the muscle is right up applied within the scar. So you can't...
Was that pre-treated?
No.
That lesion pre-treated somewhere else? Somebody tried to resect it?
Yeah, this is a previously attempted lesion. Yeah.
Okay.
Well, this is the typical situation in serrated polyposis. So when you're whizzing around the colon, if someone's got they've truly got serrated polyposis and they've had a lot of lesions removed before, you should find multiple scars. And some of those scars may have residual serrated tissue in them. So this is a typical situation like that, and we can see with this adherent yellow mucus that there must be residual serrated tissue there, and indeed there is. So under those circumstances, you need to be very careful about the excision not to injure the muscle layer, because it's evidently very possible. So you could inject. I mean, I didn't because I do a lot of this, but so you excise carefully.
But your general recommendation was inject, right?
I think you should inject here, but not in the scarred area. So if you're going to inject to resect in relation to a lesion that has been previously attempted or scarred, you must inject away from the scarred area to find the submucosal plane. Because if you inject in the scarred area, the plane doesn't exist, or it's virtually absent. So to find the plane, you have to go to the easy area, even outside the serrated tissue, and then follow it in. So you start the resection from the normal to the abnormal scarred area.
But my question was, the general recommendation for the not previously treated ones is also inject.
If they're
because you said sometimes you don't have enough time.
If they're larger than 10 millimeter, I think it's a good idea to inject. But just to make the point here, you can see why you need to be careful, because look at that. You never see that appearance in conventional cold snare resection for a naive lesion. You don't see the muscle like that on display within the defect. That's because of the scarring and previous attempt. Mm-hmm. And obviously the mucosa in this area was very closely applied to the muscle. So to remove it, you need to be careful, and you mustn't do traction or avulsion. You mustn't pull it against the end of the scope, because you will get a perforation.
So this recommendation with the amputation is for the primary resection?
Naive lesions,
yes.
and never in the duodenum, because that's how we got those two perforations.
Good.
And then the other point, of course, here, these are other typical serrated lesions with, again, adherent mucus, and obviously this patient has serrated polyposis. And as the lesion gets bigger, as we said before, bleeding doesn't need treatment, but it can get messy. So we often use, if we're going to do injection, we use adrenaline in the injectate, 1 in 200,000 to sort of slow the bleeding, lots of water jet. But you can imagine here how, if you're not systematic and careful, you could easily miss some residual serrated tissue. So you have to follow from one direction to the other, usually from left to right, and water jet, try and minimize the bleeding. And when in doubt, for example, here, like I would normally excise that area there.
Just gone.
Yeah.
You want to have straight margins anyway.
Yeah.
And not these bizarre landscape-like lines.
So, and as I mentioned, for extensive lesions, we do, this is, like a very large serrated lesion. We do submucosal injection. This minimizes the bleeding, and then you end up with a beautiful resection here. Here was a protrusion that we flattened out and then re-excised. And overall, the data in serrated lesions, we showed in the paper that we were able to publish in Gut, comparing hot versus cold, the previous era with the cold era. The recurrence rate was only 2-3% in the serrated lesion arm, and they were all larger than 20 millimeters. So it was all cold snare EMR. So these are the general principles: follow the margin, recognize residual, minimize oozing bleeding, and that improves your ability to resect the lesion. And then with extensive resections, this is almost fully circumferential. You see a scar in follow-up. So here is almost fully circumferential serrated lesion that we've excised by piecemeal cold snare resection. If we'd done this by hot resection, big issue. Patient has to stay in, for sure. This is a huge resection. They're going to get pain. They might be in for 1 or 2 days. You'll worry about bleeding. It's just above, it's proximally sending. So bleeding risk is going to be 10 to 12%. So circumferential proximally sending colon SSP, excised by piecemeal cold. Huge appeal for this technique because no risk of perforation, delayed bleeding is eliminated. And with that sort of case, you'd have to admit the patient, they definitely have pain afterwards, and you can't clip it up, so bleeding risk is 10 to 12%. So the cold eliminates all the problems. And then here we come to the 12-month follow-up. So here we have the 12-month follow-up, and you see small nodule within the scar. So is this recurrence? Well, let's just go back a little.
Well, it's either hyperplastic or recurrence, but you don't know.
I'll start again. I'll just go. So at 12-month follow-up, we see a small nodule within the scar. So question is this recurrence? And if we look carefully, you'll see that the pit pattern within the nodule is the same as the surrounding pit pattern within the scar. And the pit pattern within the scar is the normal type 1 pit pattern, except the pits are a little bit more prominent, as they often are, and a bit more open. And then here, the pit pattern within the nodule is the same. But if you see a nodule within a scar at follow-up,
better take it out.
Take it out, yeah. But we can take it out cold because we're committed to managing this patient cold. So, so we take dedicated snare, push down really hard, and then cut through. Again, push down really hard, cut through, but be mindful. Generally, you don't want to do traction like that unless you've got no other option. So we widely excise the scarred area, and then we can be certain. And then here's the technique. Watch my hands. Push down with the up, down, stage snare closure, and then cut through. And then lots of water jet. We've excised it. In fact, it was just nothing. So this patient at 12-month follow-up cured from this large serrated lesion. Yeah, so in summary, therefore, for serrated lesions in 2024, small lesions less than 5 or 5 to 10 should all be managed by cold snare excision. As I mentioned, low mucosal profile. These lesions are thin and the tissue is soft, so you can definitely excise with confidence. Even 10 to 20 millimeter should be removed by piecemeal cold snare excision, and greater than 20 serrated lesions of all sizes should be managed by cold snare excision. Just to make the point that when you're looking at a serrated lesion, it should be homogeneous. If it's not homogeneous, if you see an area, particularly a nodule or depressed area, that has a different colour or pit pattern to the surrounding area, then particularly if you're in the right colon, you're often looking at a serrated lesion with dysplasia, and they need to be managed in a different way. If there's a depression, and this is the typical appearance of a serrated pathway cancer. You see some serrated tissue around the edge, a depression, and often these can be T2N1 with limited evidence of the disease on the luminal surface. So it's a bit like dysplasia and cancer within IBD polyps. They often are actually worse pathologically than they appear from the luminal side.
But what would you do primarily, even if it's a diagnostic resection for the lower middle one?
Yeah, so this of course can be removed. It's
using what?
Well,
hot.
No, cold.
No? Cold. Cold. Okay.
Yeah. So
still.
Yeah. So what you do is remove the dysplastic area first. If it's a bulky nodule, well then probably you should change to conventional hot EMR and remove that first. We know that a serrated lesion with dysplasia becomes a cancer very quickly. We know that from the Bettington study, which was published in Gut in 2016. Excellent study, showed that the age of patients with dysplastic serrated lesions and the age of patients with serrated pathway cancers was the same, but those with serrated lesions alone without dysplasia, they were about 15 years younger. So once you get dysplasia, the implication being that once you get dysplasia, it turns to cancer very quickly. So if you were to do a molecular profiling on the dysplastic area, of course it has a BRAF mutation, but also they often have MLH1 or one of those other mutations.
So this would probably be a hot resection.
Well,
very few examples. I know that you are on a cold obsession now, but
no, I'm not.
Shouldn't we agree that this?
Yeah, this should be a hot
okay.
resection, but you should submit the dysplastic components separate to the other lesion. And then the other caveat to that, which is very important, when you're removing polyps from the colon, you generally submit them. We don't submit every polyp separately. You submit them separately in segments. So if you did 3 or 4 polyps in the ascending colon, you should submit them as one. But if one of those is a serrated lesion and the others are adenomas, you should submit them separately, because then the pathologist can get confused and they might say, oh, there's a serrated lesion with dysplasia. And then that creates a whole other paradigm. The patient's put into a high-risk group and they need early surveillance, whereas if they've actually got just one serrated lesion and 2 adenomas, they can come back in 3 to 5 years, whatever the national guideline is, as opposed to 6 to 12 months. So make sure you don't mix up serrated lesions and adenomas when you're doing polyp retrieval.
So the lower right one, full thickness or nothing?
Oh,
straight to surgery?
no, straight to surgery. Yeah.
Straight to surgery.
Yeah, this was a patient who had a lesion resected in that area 12 months earlier by the referrer, and it was a serrated lesion removed from that site, but in fact it was probably a serrated lesion with dysplasia, and it wasn't recognised that there was some adenoma or dysplastic change nearby. So.
But still, if I fight for the full thickness aficionados, what's wrong to get a super specimen and then do surgery?
Well, say it's a T2 cancer and you cut through, it's an incomplete resection, then haven't you contaminated the peritoneal cavity? Yeah, I just...
Okay,
yeah.
That's another paradigm which is sometimes doubted, but okay.
Yeah.
So if it looks that bad, then it's no shame to send an occasional patient to surgery.
It's no shame to send advanced histology to surgery. Surgery has an important role. We mustn't forget that.
Yeah. Okay, that sounds like a very nice conclusion. So thank you very much, Michael, for this episode, and we are eager to see the next one.
Thank you.
Okay.